everyone, welcome back to my channel. In this video, I'll be continuing on the antimicrobial stewardship strategy of IV to oral step down. Recall that in my first video, I introduced you to what this entails, the two main types of IV to oral step down, the benefits to your patients, including reduced side effects by getting them off IV therapy, and to the 7 principles that you should consider whenever you're reviewing your patients for an IV to oral step down. This video will focus on the first type of IV to oral switch, which is sequential therapy. Sequential therapy refers to you're switching your patient's IV antimicrobial agent to a highly bioavailable oral form that is of the same drug. So in order to figure out whether your patients would be candidates for a IV to oral sequential therapy switch, you need to be familiar with the oral antimicrobial agents that have high bioavailability when given via the oral form. I've listed on the table here some of the most common ones we see, and they include ciprofloxacin, clindamycin, cotrimoxazole, fluconazole, levofloxacin, moxifloxacin, metronidazole, and your antifungal voriconazole, along with their corresponding percent absorbed orally. And you can see that they all range from 70 to 100%. Meaning when you give these medications via the oral form, they achieve a very similar serum concentration as compared to their IV formulation. So to identify those patients who would be a sequential therapy switch candidate, look for patients who are on the IV versions of these medications. So once you've identified your patients who would be a potential candidate for an IV to oral sequential therapy switch, recall the 7 principles mentioned in the first video whenever you review patients on whether it's appropriate to switch their IV to an oral form. And I've listed it here again for your reference. To summarize, basically when conducting a sequential therapy IV to oral switch, determine whether your agent is on a IV antimicrobial agent with a oral equivalent that has high oral absorption rate. If yes, then apply the 7 principles to see if they would be a good candidate for IV to oral step down. I'll illustrate how I use the 7 principles to conduct the following IV to oral sequential therapy switch for Mr. LL. So I'll introduce you to Mr. LL first so that you have the context. Mr. LL is a 75-year-old male admitted for Enterobacter cloacae bacteremia due to acute cholangitis. The obstructing gallstone that was causing this cholangitis was removed yesterday with an ERCP procedure. Today on your review, he's on day 3 of ciprofloxacin therapy at a dose of 400 milligrams IV 2 times a day. His past medical history is significant for type 2 diabetes, hypertension, and anemia. You note that Mr. LL is also on the following medications. You have ramipril, amlodipine, metformin, and ferrous fumarate at the doses listed above. He is growing Enterobacter cloacae in his blood cultures that is sensitive to ciprofloxacin, cotrimoxazole, and ertapenem. His labs show that his serum creatinine has been stable at 50 micromoles per liter with a corresponding GFR of above 90 mils per minute. His LFTs are also downtrending since his ERCP procedure. You note from his nurse and MAR that he is tolerating his liquid diet as well as oral medications without any vomiting or profuse diarrhea. He's been hemodynamically stable with a good heart rate and blood pressure and has been afebrile for the past 3 days. Now that you're familiar with Mr. LL, you know that he is on IV ciprofloxacin, and we know that the oral equivalent form, which is oral ciprofloxacin, has high bioavailability, making him a candidate for a sequential IV to oral switch, as long as he meets the 7 principles. So to go through them, number 1, we need to consider whether there's a continuous need for antimicrobial therapy. In his case, yes, because we're treating a bacteremia. Number 2, there's no evidence in his chart that we're treating a condition that may require prolonged IV therapy, such as meningitis, endocarditis, or a endophthalmitis. Number 3, he's clinically stable, and you can find this out through his vital signs. He has stable blood pressure, his heart rate is normal, and he is now afebrile for the past 3 days. Number 4, we also note that he is clinically improving. He's been afebrile for the past 3 days, and his liver function test has been downtrending since his source control procedure from yesterday. His white count is also normal. He is tolerating his oral diets and medications as according to his chart and nurse. There are oral options available based on the sensitivities of the Enterobacter cloacae cultures, and he doesn't have any GI abnormalities such as small bowel that would affect his oral absorption of oral medications. Now that we've determined that Mr. LL is a prime candidate for an IV to oral switch of his ciprofloxacin therapy, we now need to make sure that this choice of agent is the most appropriate for him. Recently, I did a video on being mindful with antimicrobial prescribing, where I introduce you to the mindful acronym that consists of factors that we should always consider whenever we're reviewing our patient's antimicrobial therapy. So M in this acronym stands for microbiology. Our choice of agents should always be directed at the pathogen's culture and sensitivity result. I stands for indication. Is the site of infection penetratable by this choice of agent? In this case, we're dealing with a bacteremia caused by a gallbladder etiology, and so we know that ciprofloxacin can be used in this indication, and it will get to the site of infection in the blood as well as the intra-abdominal tract and gallbladder in sufficient concentration, as long as it's dosed correctly. N stands for narrow. We always want to pick the narrowest spectrum to treat the infection. In this case, the Enterobacter cloacae is sensitive to 3 antibiotic. It is sensitive to ciprofloxacin, which he is currently on right now, cotrimoxazole, as well as ertapenem. If you compare the spectrum, ertapenem would be unnecessarily broad for his indication. Therefore, ciprofloxacin is again an appropriate choice here. D stands for duration. Since we have source control and there's no deeper focus of infection, such as an intra-abdominal abscess, then 7 days would be a reasonable option. And this is because in the last few years, there's been more and more studies that have demonstrated that treating a gram-negative bacilli bacteremia with adequate source control and without a deeper focus of infection, a 7-day course would be sufficient. F stands for find the right dose. I will refer you to your local institution guidelines in terms of dosing for oral agents. In this case, ciprofloxacin 500 milligrams POBID would be appropriate for his kidney function and the indication of the infection that we're treating. U stands for understand the drug. We know that ciprofloxacin, when you're giving it orally, it does interact and bind to positive cations, such as iron, calcium, magnesium, potassium supplements, for example. So meaning when we give the ciprofloxacin, we'll have to be mindful of his oral iron supplement that he's currently on to make sure we space the two apart so that he would get adequate absorption. So understand your pharmacokinetics and pharmacodynamic of the agent that you choose. L stands for lose the double coverage. In this case, we're only using one agent, so we're not that concerned about double coverage. So after your assessment, you find out that Mr. LL would be a good candidate for an IV to oral switch, and ciprofloxacin is indeed the right choice for him. You suggest to the team to change his IV ciprofloxacin to oral ciprofloxacin at a dose of 500 milligrams orally 2 times a day, given at 8 o'clock in the morning and 8 o'clock at night for 7 days total, counting from the day of his IV ciprofloxacin therapy start. You also suggest that they change the iron supplement timing to lunchtime to space apart from the ciprofloxacin dose. Again, it's important to collaborate with your team of physicians and nurses to gather these information and for assessment to make sure that you're not missing anything. I hope you found this video helpful, and I look forward to seeing you in my next video where I will focus on step-down therapy of the IV to oral switch.